Hi, everybody. Welcome. My name is Sofia Gruskin, and I direct the Institute on Inequalities in Global Health at the University of Southern California. And it's my great pleasure to welcome you to today's dialogue on the WHO's Safe Abortion Guidelines and their current use and effectiveness both locally and globally. And our event is going to explore the realities of abortion provision in the current moment around the world, and with a specific focus on what's happening in India and here in California. And I want to start with a huge thank you to Antonella, one of our great panelists from WHO, for being a thought partner and a co-organizer for this, what I consider to be a much needed event. But Antonella, your dedication to helping make this happen is really much, much appreciated. Before I introduce our panelists fully, I wanted to share a little bit about why I'm excited about this event and why I feel it's really important that this be happening right now. So first is our wonderful partnership with WHO, and particularly the Department of Sexual and Reproductive Health and Research and HRP. I mean, I'm really grateful for the decades of work we've done together, but I'm really grateful for the ways we and others are partnering in trying to address the realities of abortion care now in this current political moment in the US and in all of our countries through this sort of event, through research initiatives, through student programming, and all the different ways that we all work together across our institutions. And just to say a couple of things about framing. So the WHO abortion guidelines and the competency standards were released in March of last year, so shortly before the Dobbs decision came down in the United States in June. Now, the guidelines, of course, they're excellent, but they provide a baseline and an approach for how to ensure safe and accessible abortion care within a framework of sexual and reproductive health and rights, and with explicit attention to the legal and policy environment, something that I think many of us think is crucial in this complicated moment and too often has not been a part of these conversations. And that's why, as a global health person based in Los Angeles, these guidelines in this conversation feel so important. And why in this moment, when we're dealing with the really grave repercussions of Dobbs, even in a state like California where abortion is accessible, it's really important to have conversations like these. So this panel brings together clinicians, civil servants, implementers, lawyers, focused on the provision of abortion services from all their various perspectives and working in various different places with very different realities based in Switzerland, in India, and in the state of California here in the United States. So if you'll allow me, I'd like to say only one thing about the US for a moment in the context of this conversation. And I want to flag the recently released concluding observations on the United States in the decisions of the Human Rights Committee, which monitors implementation of the Covenant on Civil and Political Rights, which the US is a state party, in case people don't know, but it came out about 3 weeks ago. And for those who haven't picked it up yet, it makes for really interesting reading in many areas. But in terms of why I bring it up here is in their many recommendations, the committee writes that it's alarmed at the increase of legislation, barriers and practices at the state level that impede access to safe and legal abortion, and the criminalization of various actors linked to their roles in providing or seeking abortion care. Well, I think we all feel that way on this Zoom, but I'm reading it now because they then went on to state the need in the US for an intersectional and culturally respectful approach in both policies and programs to improve access to comprehensive sexual and reproductive health services, including abortion. And I appreciate the words from the concluding observations, because in my mind, at least, they point to the potential use of the guidelines here in the US in ways they haven't really been used before here as they have in other parts of the world. So anyway, I'm happy for this panel. I'm hoping we can have a good and honest conversation about process, about implementation, about effectiveness as it's relevant to our various contexts. So just to say in terms of this conversation, audience people, please use the Q&A function. You've all done this a million times for any questions you might want to pose to our panelists. I will take time at the end to be able to include this in our discussion. And I'm going to very briefly introduce our esteemed panelists, knowing that you have seen their amazing bios online. So just very quickly, because there are so many of you, if I'm honest. So Antonella Lavlanet is a medical officer in the Prevention of Unsafe Abortion Unit at WHO in the Department of Sexual and Reproductive Health and Research. She's a physician, a lawyer, and a policy specialist. And to note, she acted as the lead coordinator for the law and policy and human rights domain for the abortion care guidelines. Brian Wynn is an associate professor of obstetrics and gynecology here at the Keck School of Medicine at the University of Southern California, and he's the USC Family Planning Fellowship Program Director, including the Fellowship in Complex Family Planning, focused on subspecialist training and research training and clinical practice in abortion and contraception, and he's an abortion provider himself who's really dedicated to supporting and shaping the careers of academic physicians who are focused not only on protecting, but expanding reproductive options and autonomy. And someone I'm very grateful, I have to say, to have as a partner here at USC. Aparna Sharma is a professor in the Department of Obstetrics and Gynecology at the All India Institute of Medical Sciences in New Delhi. She's a maternal fetal medicine specialist and secretary of the Fetal Medicine Specialists in India, the largest society of fetal medicine in India. She's been instrumental in developing the methodology of point-of-care quality improvement in association with WHO and with USAID, and she's conducted numerous workshops on these issues. Ruth Dawson is a legislative attorney with the ACLU California Action, where she advocates for policy on issues related to gender, sexuality, and reproductive justice. And most recently, before that, she worked in federal policy with the Guttmacher Institute, and she just finished her tenure as co-chair of the California Abortion Alliance. And she has expertise that stretches to a broad range of reproductive and sexual issues, including eliminating religious restrictions on reproduction and gender-affirming care. Priya Karna is the technical officer for reproductive and adolescent health at the WHO country office in India. She's a medical doctor from Nepal. She trained in obstetrics and gynecology in India and in public health at Johns Hopkins in the US. And she leads sexual and reproductive health programming, including gender equity and rights, for the India country office. And she's got more than 10 years of experience in this area. And finally, last but not least, is Ulrika Renström-Loy, who's a technical officer based in the Department of Sexual and Reproductive Health and Research at WHO, who provides country support, preparing policy and evidence briefs and other strategic documents. And she's got more than 15 years with UNFPA and WHO in SRH programming, leadership, representation, and coordination. And she's worked in many countries around the world. So you see an amazing group. A warm welcome to all of you. And with that, if I can begin with my first question, and I'm just going to start with whoever I see first on my screen. So could each of you orient us briefly to the kind of work that you do, the framing that you bring to thinking about and addressing sexual and reproductive health and rights and abortion specifically? And if you don't mind, Antonella, may I start with you?
Great. Thank you so much. And thank you so much for having me with you here today. So in terms of what I do specifically, I mean, you'll have heard already that I had the particular role in developing, alongside colleagues within the unit, the abortion care guideline. And so my area was specifically focused on the law, policy, and human rights aspects. But within the guideline, we discuss various factors linked to things like creating an enabling environment for quality, comprehensive abortion care. And so I work to support countries on health system strengthening in the delivery of this care, which is linked to either program design, policy intervention, but also in the collection of data. So that means conducting research as well. And then finally, I support countries towards ensuring respect for human rights within a supportive framework of law and policy. And so I often support them in law and policy design or reform. And just one quick note to mention, within the guideline, we obviously cover training and equipping of providers. And we have a subsequent product, which is the competency framework specifically that Dr. Ulrika Renström-Loy will speak to.
Thank you for that. Absolutely, 100%. Let me go, if I may, to Priya next, who I see on my screen.
Sure. Thank you, Sophia, and thank you, everybody, for joining today. In my role currently, I think while the WHO headquarters is primarily responsible for developing guidelines, when it comes to the country level, our work is more, I would say, grassroots. We work very closely with the Ministry of Health. Every WHO country office works closely with the Ministry of Health in their respective countries. I look at primarily supporting the government of India in adopting global guidelines, looking at whether they are feasible, whether they are adaptable, whether they are relevant at the country level. Particularly happy and excited to share that in the last few years, Ministry of Health, Government of India changed its abortion law, and WHO was a close partner in the MTP, or the Medical Termination of Pregnancy Amendment. So broadly, I would say the role of the WHO Country Office for India, and particularly mine, is to work at the national level to take the global guidelines, adopt them, and implement at the country level. And this also translates not only into laws and policy changes, but also seeing through in terms of its implementation, whether it is capacity building, whether it is looking at what are the new innovations that can be done at the country level. For example, we adapted the WHO global guidelines and developed something called the Safe Abortion Values, Evidence and Rights, or SAVER framework, which is a great example of taking WHO global guidelines and converting it into national level and making sure that it's used and widely disseminated. So that's just an example of the kind of work that we do at the country level.
Super helpful. Thank you. Welcome, Ruth, please.
Yes, thank you, Sophia. It's so nice to be here. My name is Ruth Dawson. I use she, her pronouns. I've spent the past decade of my career as a policy advocate. I'm trained as a lawyer working in California state and US federal policy. I have had the pleasure to work on abortion rights and coverage and access for Californians, including folks who historically and currently face barriers to care, such as young people and people in carceral settings, such as jails. And before I went to graduate school, I managed an abortion clinic in the San Francisco Bay Area. So I interacted with patients and providers on a daily basis, and that experience will forever inform how I do the broader systems work. In addition to my day job as a legislative attorney at the ACLU California Action, which is the state's C4 lobbying arm, I'm also on the board for the California Abortion Alliance, which is an incredible network that advances access to abortion care across the state by connecting and supporting professionals in abortion provision, law, and research. And we have, of course, as everybody else, been very busy since the Dobbs decision. So I work for a civil rights organization, and I also have a background in global public health and law. And so it's a bit of a multi-pronged perspective. In that direction, I've learned from colleagues and predecessors to do this work aiming for reproductive justice, which aims for a world where all people can choose if, when, and how to have children, and to parent the children they have with dignity and respect. So abortion is one piece. It's an important piece of this much broader picture.
Great, thank you and welcome. Aparna, may I turn to you?
Hello, everyone. I'm really happy to be here today. I'm a professor in the Department of Obstetrics and Gynecology at All India Institute of Medical Sciences, New Delhi. My area of interest is high-risk obstetrics and fetal interventions. But besides being a clinician, I have been actively involved in public health and community obstetrics. Through the years, I have been involved with the family planning programs in the department and in the state. I've been involved with in bringing about actually a change at the level of the frontline workers using various quality improvement methodologies, which is an area of my passion. After having worked extensively in this area, I feel that being able to have a reproductive choice is one of the greatest freedoms that we can provide to our women. But this is such a complex goal and task that however much we do in this area, it remains to be desired. With the changed MTP law in India, the legal standing is there. I had been involved with the framing of this law, the ethics of this act, and we are really proud of the freedom that it provides. And I'm a passionate worker in this area of reproductive health, and going forward, I think we have a lot to do in terms of guiding policy and implementation in its true length and breadth.
Thank you. Welcome. Ulrika, may I turn to you?
Thank you so much, and thank you for having us. So my interest is health system strengthening, and specifically when it comes to health workforce, because family planning and abortion care, it's a primary health care, sits within primary health care. And if we don't have skilled health workforce, then it's difficult to also provide quality of care. So I have been the technical lead of the family planning and CAC toolkit for primary healthcare workforce, the same that Antonella mentioned, and I have worked closely with countries such as India to strengthen their health system when it comes to sexual and reproductive health, but specifically with the lens of abortion care. And now I continue to support countries to implement the family planning and CAC competencies and support them to develop competency-based curriculum and in-service training. Thank you.
Thank you. Thank you. Brian, please. Wait, you're muted.
Excuse me there. Thank you for having me as well. I'm a full-time OBGYN who provides and teaches abortion procedures with a focus on the provision of complex later gestational age cases that require hospital care. We at the Los Angeles General Medical Center are the safety net for abortion care in Los Angeles. As we all know, more than 90% of abortions occur during the first trimester, but those that occur beyond this point tend to occur among low-income, uninsured, disempowered individuals who are more likely to also have risk factors and comorbidities that make providing abortion in the outpatient setting unsafe. As a hospital-based abortion provider, we support that need. We're also one of the only sites that provides abortion care to pregnant individuals in the carceral system, as well as those receiving acute psychiatric care. So in short, we provide clinical support for groups who otherwise face numerous obstacles, social challenges, and restrictions to abortion. An additional facet that I bring to SRH care is research on men's engagement and utilization of SRH care, inclusive of abortion. I'm a consultant to the WHO's interests in men's use of contraception and interest in novel male contraceptives that are currently in development. In that vein, I do believe that acknowledging men's interest in abortion and recognizing that men can be beneficiaries of abortion is a critical consideration in creating advocates for and ensuring women's access to safe abortion at multiple levels.
Thank you. All right, everybody, you see this is a great group, right? This is a wonderful group of people. So, all right, let's plunge in. And Antonella, can you start us up? We've been talking about the safe abortion guidelines. Okay, so why were they created, right? Who's the intended audience? How are countries meant to use them? How do they work with their legal environments? Can you just orient us kind of in big in terms of the guidelines, and we'll take it from there.
Sure. So first, it's important to note that WHO has actually been issuing guidance related to abortion for 30 years. So this particular guideline brings together all of the recommendations that we have on abortion in one place. And it updates existing evidence where applicable and provides new recommendations in areas that we didn't have before. In this guideline, though, we also have emphasized the need to center abortion care around the needs of the individual seeking or needing the care. As Ulrika mentioned, abortion is healthcare. And the guidance really is seeking to provide recommendations for national and subnational policymakers, implementers, managers of sexual and reproductive health programs, including members of non-governmental organizations and other civil society organizations. We also work very closely with professional societies. And we know that multiple actions are needed at legal, health system, and community levels, so that everyone who needs it can have access to comprehensive abortion care. And so the guideline really sets the stage for all of these pieces and all of these components. So the intent is to support individuals in ensuring that evidence-based quality care is available and accessible globally. So this really means considering the enabling environment. And what are those elements for us? So I mentioned one earlier, respect for human rights, including a supportive framework of law and policy, availability and accessibility of information, and a universally accessible, supportive, affordable, and well-functioning health system. So the countries look to the guidance and often seek our support in updating their national guidelines, for example, or as they review their national policies or laws. But beyond our guidelines, we work with states to consider the way in which these services are structured and accessed. So we engage with them on issues related to things like monitoring and quality assurance, financing and costs, and so including around reproductive health technologies, as well as training and equipping. Many of these components we know are addressed within national law and policy frameworks, and many of them require hands-on training on the ground. Over to you.
Great, thank you. Super helpful. I mean, and then I think related to that then is the competencies framework, right? And so then I guess, Ulrika, if I may ask you, can you talk us through the competencies framework? Can you talk about, any data you have on how much they're used or not, the kind of rates of uptake there is, and any data you might have in terms of being able to talk about success, about issues to be addressed, anything about kind of looking at this globally would be super helpful.
Thank you. Yes, so the family planning and comprehensive abortion care competencies, they came out in 2022. We have, there are many countries that are very interested in the competencies, and we have specifically worked with the East, Central and Southern Africa College of Obstetric and Gynecology, EXACOG. They have developed a specific module on abortion care based on the competencies. We are also working closely with FIGO and ICM, the two professional associations, and they are very keen to start the implementation and the use of these competencies. It's not an easy task to start engaging with partners to work on these ones, and here even India has been pioneered in implementing the competencies. They have worked very close with the professional associations, specifically the midwives, and they have revised, and I'm sure Priya maybe will talk more about this one. But we are to evaluate the competencies, we are to evaluate the implementation. We still don't have specific data, but anyone who is interested in these competencies, we have them in English, French and Spanish, and we are available to support countries and institutes that are interested to start working and to have a competency-based education when it comes to abortion care.
Super helpful. Again, thank you. I mean, I want to get concrete, and I want to drill down, and let me start with colleagues from India, if I may, and then we'll move to California. I mean, so can you talk about, having used the guidelines and the corresponding competencies, how has that worked? Are there successes? Have there been challenges? I believe there's been some challenges were just referred to, so I'd be interested if you could talk to us about that. But how have you engaged different stakeholders to apply and use them? Like, that's really a question that I think people really want to understand about how does that work? And if I may ask, how do you situate action around the guidelines in India's current political moment? I think it's something that we're trying to learn here, and so would be really grateful for anything about this. And just in general, and I'd like to ask you to decide who's going to speak first, but I'd like to hear from both of you. So who would like to start? I can, please.
Yeah, can I?
Please.
Go ahead.
So I think, our work on WHO guidelines started, and I think we must really say that, Priya and me, we have worked as a team over the years, since the last 4 years, on abortion guidelines, various activities around abortion guidelines. I think it started in 1920, in the year 2019 and 2020, when we made an adaptation of the WHO guidelines for use in India. It was important because the service provision for abortion is specific to India in certain scenarios, like, say, for example, only doctors can provide MTP. So all of those were incorporated. We came out with a document which would be useful at the ground level for implementation. Then additionally, we had another manual where we talked about the guidelines of abortion, and at the same time, the conflation of the laws which were existing in India in relation to provision of abortion. Say, for example, these included the POCSO Act, which talks about the provision of care around victims of sexual assault, and also the PCPNDT, which talks about sex-selective abortion. And this was required because, even though we all wanted to provide abortion, we wanted to provide safe abortion, but then the existence of these acts could become barriers to service provision, and it is a reality. So we talked about that, and we came out with this so that there's clarity on this matter. Following this, in 2020, the COVID pandemic came, and we all agree that SRHR services were most affected during this period. So starting with our institute, which was AIMS and WHO India, we conducted a series of webinars which were based on the WHO guidelines on provision of care and also address the issues of stigma around provision of care. And these webinars actually had an audience of more than 10,000 doctors. And during this period, we also reached out to the paramedical staff and we talked about provision of the abortion care around this. And this almost has an audience of 20,000 healthcare providers. And it was definitely possible because of the association with the professional organization, the FOXY, which is an organization of strong 40,000 gynecologists. Following this, we had another initiative which actually started in 2020 itself and has been continuing over these years, was in association with the WHO CRO, was the competency-based curriculum around abortion. And when I hear that there are other, these things are there, so we are really excited to, share our experience and learn more from these competency-based curriculum. Now, considering the abortion guidelines, we developed a curriculum for the pre-service medical students, which are the interns. And it was felt that this provides an opportunity for all the medical providers to get sensitized in respectful and safe abortion care. So we first made the curriculum based on the WHO guidelines and then pilot tested them on 3 medical colleges. And then we took a feedback and then tested them in 10 more medical colleges. And the evidence from them, a concrete evidence from them, then we had focus group discussions, some qualitative evidence, and also which shows that there is a definite improvement and the students are very receptive and they feel the importance of the training in this format. So we have been, discussing abortion completely, in and out over the last 4 years. And I think this is something which is the need of the hour and we have a lot more to do. And we are really happy to engage further in taking this forward. So Priya, over to you.
Thank you, Dr. Aparna. I think you covered a lot. But just to summarize and just to reiterate, I think what mattered the most in terms of being able to do any work effectively in India, I would say it's persistence, preparation, and people. Persistence because, it's not a one-time activity. As Dr. Aparna said, it has taken us years. We started in 2019. We looked at what WHO guidelines are, how does it apply to the country, always remembering that it's not just WHO or WHO Collaborating Center, but there are multiple stakeholders, whether it's the private practitioners, whether it is doctors, nurses, everybody has a role to play, and trying to engage them in different avenues and different opportunities was key. So it was persistence, preparation. We all knew at some point changing the abortion law to make it more comprehensive has been a long drawn fight in India. It was an ongoing conversation for about 14 years. It's during the COVID pandemic, there was some discussion that there was, talk in the Ministry of Health that started on whether the amendment should happen or not. And I think, you talked about the political climate. I'm happy to share that the MTP or the Medical Termination of Pregnancy Amendment was the only non-COVID related amendment or law change that happened during the pandemic. It's a huge deal. It was the only law that just passed through unanimously. The first time that it went to the lower house, the lockdowns happened and it had to be passed again. And the second time it went through the lower house, upper house, presidential signature without any dissent. And it was because we had the Parliamentary Association, the providers, every single person was briefed on what the law is. And at all times, it's important to remember that whether it's the people that are working on the side of changing the law, whether it's the people that are advocating for the change or the people that are the beneficiary, there are always people, human beings at the end of it. Always a matter of pitch, trying to understand. I mean, it might sound very crass, but it's really to understand what do people want, trying to make them that pitch, trying to hit the nerve. For India, we made the case of women's empowerment. We made the case of benefit for women. We made the case of more women being able to have the reproductive freedom, to be able to enter the workforce. There's only a 20% labor force participation in India. There is a 15 million, abortion that happen every year. 25. These are big numbers. Making even the parliamentarians, to make them feel that you're contributing towards the development of the women of the country, something so important. Government of India has contributed to it, riding and aligning with government's priorities. Again, the other thing that we really tried to focus on was not, and a lot of it went under the radar. Frankly, sometimes it's better to do and not say. And I think that's what worked for us. the more we would have talked, I think there would have been more opposition. However, because it went silently, we've tried to keep it as technical as possible, it went through. So I would say, the political climate really doesn't matter. It's understanding what is the ask, being persistent, being prepared. All that Dr. Aparna said, whether it was guidelines, documents, one-pagers, frequently asked questions by parliamentarians, opposition questions, or being prepared matters. You never know when the opportunity might come. It may be today, it may be tomorrow. And I always remember the Ministry of Health doctor would always say, you might get half a minute with the minister in the elevator. What will you ask? So, you have to be very, very clear. We had videos, we had cartoon videos, some such basic explainer things, and really trying to make people feel that, it's not about abortion per se. It's about the woman, it's about the choice, it's about enabling people to participate in their lives fully. And I think that's the pitch that we made, and that's what mattered.
That's super helpful. And I just want to say to the audience, if you have questions about anything that you've heard, please do put them into the Q&A function, because I think that there's a lot that's been raised and a lot to be learned. And I'm going to turn to our colleagues in California now. So listening to our colleagues from India, right? How relevant, how comparable is the experience here? How relevant are the guidelines and the competencies to the work we do here? Do you think we're in compliance? Do you think that there are gaps? And are the guidelines useful, or are there ways that they could be helpful to the work in the current political and legal environment that we live in, or maybe not so much? And I would ask, I don't know, who would like to go first? Brian, you're unmuted. May I go to you because you are unmuted?
Yeah, sure. There are several organizations in the United States that offer guidelines and up-to-date evidence on abortion provision that respond to the unique context of the U.S. healthcare system, and in particular, the medicine and equipment supply chain. These organizations include the National Abortion Federation, Planned Parenthood Federation of America, Society of Family Planning, and the American College of OBGYN. The guidelines are primarily clinical, and they're aimed at providing pragmatic guidance on how to optimize patient outcomes and experiences pertaining to abortion. And much of that is already found in the WHO guidelines. But the WHO guidelines, I will say, go further in emphasizing abortion as a human right, and really defining the social cultural context that needs to be in place for safe abortion to be accessed both easily and widely. For example, actually what struck me was that there's a beautiful conceptual framework in the guidelines that acknowledges something that didn't occur to me for quite some time as a training clinician. Which is that safe abortion is not just about my knowing what to do with respect to prescribing or performing a procedure. For me to provide an abortion at 20 weeks gestation in this hospital, abortion has to be legal at a federal level. There cannot be state level restrictions on gestational age. The patient needs to have insurance, or the healthcare system needs to be able to cover the cost of abortion. The director of surgery at my hospital needs to guarantee OR availability. On a regular basis. I need to have a team of nurses, techs, anesthesiologists who will not conscientiously object to participate in abortion, and the patient needs to have a supportive environment to recover in. And even before that, the patient needs to feel that they can decide that they can have an abortion without fear of repercussions or judgment. And they need to not go to a crisis pregnancy center where they can be misinformed about abortion. So, what I'm describing here is that there's an entire, culture of access, and that the WHO guidelines do go further to address very strongly in talking about abortion as a, human right. And none of the multiple different aspects that I talked about are guaranteed in the United States. In fact, we may be even stepping backwards in terms of this cultural need.
Great, thanks. Yeah, totally. Ruth, over to you.
Thank you for painting that picture, Ryan. I appreciate you walking through all of the different components of the guidelines, and I can see how they would play out in my mind, even here in California. So building evidence, authoritative guidelines, support for abortion is important on every level, including the highest, which I'd consider the World Health Organization. And I imagine the guidelines are being lifted up in federal policy conversations during the chaos of the post-Dobbs era, which we have been in for seemingly forever, but it's only been about a year and a half. The question, of course, is whether we have rational actors in government office and in our federal judiciary in the states who would actually cut through the political gridlock faced with the receipts, right? Such a well-resourced and researched document. I'll say hearing about the work in India is inspiring. It's been a really devastating time in the US. It feels like the pendulum is really swinging backwards. So while I can only speak to my experience and conversations, the truth is the guidelines kind of as a whole have not really come up in the state level advocacy conversations I have been privy to in California. And it's likely because we haven't needed to cite them. This panel was actually a really good opportunity for me to review the guidelines. It's quite an impressive document. And I think that it's something that we advocates, even in states like California, really can mine for context, for kind of additional holes that we can mend now that we are past the kind of first 2 years, legislatively at least, of the post-Dobbs world. So while California is not immune from the imposition of a national restriction, such as a national ban on abortion or a particular type of procedure, after the Dobbs decision, again, which is the decision that overturned Roe v. Wade explicitly, there's enough political will at the state level to pass protective, supportive policy that we haven't really had to point to higher international authorities and sometimes not even, federal authorities. The folks may know that our governor in California directed the formation of the California Future of Abortion Council, which has been a 2-year running collaboration of advocates, policymakers, researchers, providers, patients, key constituents that were essentially tasked to determine potential challenges in the state because we could see what was coming down the pike and recommend solutions for access and stability for abortion, both for Californians and folks who are seeking services from out of state. And there has been, the situation, the chaos is constantly evolving, but we do know that folks are coming in from other states to California for their procedures. So our governor signed 15 bills at the state level in the Future of Abortion Council package last year. And this year, the same group sent 12 bills to the governor's desk. And so there has been so much activity in this realm, really trying to shore up our abortion rights and access in the state that we haven't, I think it's a really good time actually for us to kind of pull up and reassess more broadly and look to this human rights framework. I will mention that in my experience, the guidelines have been helpful in specific parts. So speaking of national threats, there is a case, folks are probably aware of, the Alliance for Hippocratic Medicine versus FDA, which seeks to restrict mifepristone, which is one of 2 pharmaceuticals, of course, typically used in medication abortion. That also threatens access to medication abortion in California. And so there have been many conversations about the misoprostol only protocol and how to incorporate that into California policy, to make sure that our public insurance system and covers misoprostol only MAB if needed, and also our private insurance would be required to cover it as well. And so there have been plenty of conversations among providers, advocates, and supporters about how to incorporate misoprostol only, and we've really relied on the WHO standards there. And just flagging for folks that next week, the Supreme Court actually will have a conference where they may decide whether to hear the appeal on that case, in which case I'm sure that conversation will reignite.
Thank you. Before I turn to Antonella, just to say that I think all of our colleagues now have raised a number of issues that people may have questions about. So please do feel free, because I'm sure in some ways we all speak in our little technical speak, and I want to make sure that everybody hears and kind of understands kind of the different things that have come up. So Antonella, please.
Great. Thank you so much. I just want to add one point of clarification. So as I mentioned, one of the things that we've tried to do this time around is really frame abortion as healthcare. And so while we have the human rights integration, we're not really speaking to abortion as a human right, but instead as, talking about the right to health, the right to non-discrimination, the right to access to information. So these are the conversations that we're having when we're working in country in particular, because most people can agree on, many of these rights. And so it starts to set a sort of level playing field.
That's super helpful. I'm going to take a couple of questions that have come in through the Q&A, because I think it's a nice way to kind of get us moving. But again, I also want to encourage panelists, if you have things you want to ask each other or things you want to add, to please go ahead. One question that was raised is about conscientious objection. And it seems like it's a really important challenge in a lot of different places and a lot of different geographies. So it would be nice if any of you could speak to strategies you've engaged in from a law perspective, from a clinical perspective, from an advocacy perspective, whichever perspective you want to bring to this, to overcome conscientious objection in any of the settings where you work. Who could start to take that?
I can start to bring it up. Conscientious objection is something that we deal with actually on a regular basis. And, conscientious objection makes it seem as if it is a active process, but sometimes what it is in the hospital setting is that abortion cares for other providers to do that other providers might not have to do. And so, part of that is creating a cultural shift. Where we educate some of our, colleagues on why we do this. And I think the WHO guidelines are actually helpful in expanding the providers who it incorporates in terms of abortion care. So it's not just doctors, it's, nurses, advanced care practitioners, and even the discussion of, self-abortion, and decriminalization. All of that language is helpful in, reinforcing that this is such care that there isn't really a need to object to or not participate in.
Great, thanks. Anybody else? Antonella, please.
So I would add, and this we talk about in our guideline as well, we don't want people who don't want to provide good quality abortion care to patients, right? And so especially where there are legal entitlements in place, it's really up to the state to figure out how to organize themselves such that services are available. So that means organizing healthcare professionals in such a way, organizing programs in such a way so that patients are not prevented from obtaining access to services to which they are entitled. And it's one of the reasons why within our guideline, we're actually not recommending against conscientious objection per se. What we are recommending is that access to and continuity of care is protected against the barriers that we know that are created by conscientious objection. So I would just add that.
Super helpful. Aparna, please.
Yeah, I think this is a real problem that we face. And being a clinician, we do come across colleagues who would not want to do this. So when we are having a group, a team of people working, so we do have mechanisms where we identify that, okay, if this is happening, you can refer to that. And this has to be a system involvement. And there are some institutions in place which as a whole don't provide abortion, but of course we cannot force them to do that. That's definitely a choice. But yes, in those places there is a mechanism where patients are referred to other institutes who do that. So I think that is, as a clinician, it's our responsibility to find those mechanisms and enable women to take that. Yeah.
Super helpful. Thank you. Ulrika, please.
Yes, so it's a little bit related to what Antonella said. So the scope of work is very important for the healthcare provider. So for a midwife, for example, if the scope of work is mentioning that all things that a midwife should do, she can't object. The state needs to make, like Antonella said, there needs to be like that legal framework that there is. If you are working in a clinic as a midwife, you can't object. Or if you are an OBGYN, there is no possibilities to object. Then you should look for some other area in the healthcare sector. So the scope of work is very important.
Super helpful. Priya, please.
Thank you. I think just to add, One other thing that we found helpful in addressing conscientious bias is addressing the capacity building workshops. WHO does have tools on value clarification, attitude transformation. While I'm not saying that it takes a day or even a week or a month, but continuous engagement with the people that are providing the services and are the gatekeepers of these services, it helps. I think in India, one of the things that we did and we have done consistently is reaching out to paramedical staff, nurses, midwives, people that may not be responsible for providing the service directly, but they are definitely those that either refer patients, or they are the ones that help people for post-abortion contraception, etc. Continuous engagement and capacity building workshops. Sometimes they might have objection. I mean, at least in our experience, when we did the first respectful abortion care workshop in India, we realized many people, a lot of the objection that people have, the Indian law at least addressed it directly. So issues of confidentiality, providing services to minor, consent, etc. We were lucky in the sense that the law itself clarified many of the misconceptions and the biases that people had, and several objections that are conscientious, that pertain to conscientious bias, through continuous engagement and always reminding people the duty of care. I think that in many cases, at least for us, we've been lucky in that way, that has helped to override many of these barriers. So I would say continuous engagement and capacity building is also a key part of overcoming these challenges.
Thanks. There's a specific question that came in on this, which I'm going to go to, despite I have all sorts of other questions in the list, but I want to come to this one first because I think it's super relevant, which is whether there's any legal validity to conscientious objection in India, especially for MTP providers in public health facilities. Is it any different? How is it different from service denial? And are there guidelines around this? If colleagues have any response to that question.
Sorry, go ahead, Priya.
Hey, Dr. Panna, go ahead. I'm trying to read the question again.
No, so legally, I mean, yes, of course, any facility is supposed to provide abortion, but legally, in terms of like saying it black and white, there is nothing like that. So people actually make arrangements on their own, and so that the care is not suffering, but it is not there in the MTP Act. No.
Okay. Thank you. Priya, anything to add to that?
Yes, actually, under the rules of the MTP amendment, there are recommendations on what a facility should look like, what the facility, what kind of provider should be at the facility. And with the new amendment, it goes all the way down to the primary healthcare facility. The rules within the law, the overall ambit of the law, the parameters that are within the law, who can obtain services up to 20 weeks, which provider can provide the services, when to provide medical termination, when to provide surgical termination, at what level of care do you provide these services. Those things, I think, are pretty well laid down in the law. There is a supplement to the law, which is the rules. That does clarify much more on, what service, who to provide the service. And these are all recommendations. While I'm not sure what it means by validity to conscientious bias, I would say that, for the most part in India, at least what we have seen, abortion is not new. It has been something that has been, it has been legal since 1971. So it's been 50 years of legal abortion in India. There have been other challenges in India, conflation with, the prevention of sexual abuse or the prenatal sex determination. Those are other challenges that are the reality of our country. And, balancing the act is very, very important. While it is important to be able to provide service to everybody that needs it, in India, the reality was also that it has also always been a reality that, there are these other factors that also need to be taken into consideration. But I do think that with the new law, there is a lot of scope, there is a lot of hope, and there is a lot of work that is to be done by all of us.
Thanks. Thanks. I'm gonna, if I can, I'd like to talk to our California colleagues for a moment in terms of this. And I'd be interested in understanding it. It was really clear that in India, part of what brought about the change in the law was this large coalition of partners that were able to work together, that was really kind of critical. And I would be interested if you could talk a little bit in terms of both in California, but also potentially federally, in terms of what the coalition of partners looks like now who are trying to address the Dobbs decision, and essentially how is it that folks are working together across. Ruth, can I start with you on that one? Is that okay?
Sure. That's such a great question. I would say there are kind of three primary groups that have been coordinating in this space. We have the long-standing California Coalition for Reproductive Freedom, which has been around for decades now. That's advocates from across the state who do state and local work on reproductive freedom writ large, so including abortion rights, but not limited to. We also have the California Abortion Alliance, which is the group I was mentioning, which is a bit of a medical legal partnership where we kind of get down to brass tacks. You know, the lawyers bring conversations to the providers bring conversations to the lawyers, and there are other kind of researchers, administrators that actually talk about the nitty-gritty of abortion provision in whatever landscape we're in, you know, and currently it's been very helpful because we are in a pretty rapidly shifting landscape. Of course, federally and also in California, and both of those levels, you know, are pertinent to our work. And then we also have the Future of Abortion Council, which, as I mentioned, is a bit of a newer, kind of newly, a bit of a newer genesis, started by the governor, that includes policymakers, so elected officials and other folks as well. And so each of those groups has a slightly different charge, but we have been coordinating and working together to make sure that kind of all folks are brought in, because we don't really have much capacity to lose at this point. And the good news is that a lot of folks, whether they be providers or advocates or otherwise, are involved in, you know, one or more of those spaces. And so if anybody watching is interested, for example, in joining the California Abortion Alliance, we make sure that to vet our members, because it's security and safety is really important to us, especially when it comes to our providers. We want to make sure that it's a really safe space to have those conversations, and to also get support that folks need to be able to provide these crucial services.
Thanks. I mean, it really does point to the differences in our different environments, right? And in terms of just how we are thinking about how to address this. I guess, you know, I have a question then, if I can. I mean, I think we're all sort of struggling right now in our different environments around abortion access, right? And how to ensure it in kind of the global political moment as well as the local political moments that we live in. And I wonder if I could ask each of you to talk about and to take a few minutes to talk about kind of what actions you're involved in that are you're aware of that are really focused on securing abortion access. And I mean that in regards to your own work, but I also mean in terms of just kind of for people to understand essentially the environment that we're in, really. And I would love if I can ask, for some folks, I think it'll be more clear, the folks from WHO, but it's like, how are the guidelines relevant to what it is that you're doing? Like, how are guidelines part of this? And I would really love to hear more about policy reform, about collaborations, but also, and I think this is what's critical in terms of a conversation like this, areas that need support, areas that need momentum, where you're seeing that things are lagging in ways that you would hope that they would not, and perhaps where there's things to be learned from one another. And I don't know who would like to go first on that. I realize that was quite a mouthful. Brian, you unmuted, so I will go for you.
Yeah, sure. I mean, addressing the question of how the guidelines are relevant to the current work that we're doing now, and they're progressing the work that we're doing now. You know, Ruth characterized California as being a very, very progressive state in terms of its actions in trying to ensure abortion access. But one of the impediments that we currently face in California is a indirect gestational age limit on our abortion care. The WHO guidelines, you know, are very clear that we should not have these gestational age, you know, limits, and you know that kind of guidance, bringing that to our hospital administrators is actually very helpful in helping to expand the care that we provide. To be more specific, While California does not have a specifically stated gestational age limit, it does talk about a viability clause that like the clinicians in my hospital have defined at around 24 weeks gestation, unless the pregnancy poses a mortality risk or the fetus has a condition that precludes survival outside the womb. And that creates a reason why I have to turn away some patients sometimes when they do want to have an abortion. So I will be taking that to some of our hospital administrators.
Great, thanks. Thanks for that. Ruth, can I turn to you next? Is that okay? It occurred to me, it's good to put California together.
Yeah, I'd love to stay in California for a minute and then listen to our colleagues from India. So yes, even in California, right, we have a lot of good laws on the books, and we know that we also have more work to do. An example of this is actually the first recommendation in the guidelines. There's a strong recommendation to decriminalize abortion. And this is one of those things that was surprising to many people, but kind of even in California, we have seen unscrupulous prosecutors go after people for their pregnancy outcomes. And so last year, actually, AB 2223 in California by Assemblymember Buffy Wicks was in line with that recommendation. I was happy to work on that bill along with wonderful advocates throughout the state. It passed and was signed and is now law in California. That law ensures that no one in the state will be criminalized, meaning investigated, prosecuted, or incarcerated for a pregnancy outcome, whether that's miscarriage or abortion. Because we were seeing that, right? The laws on the books were such that there was kind of a loophole for prosecutorial discretion. And so now there are mechanisms that we believe will prevent that in the future. Of course, implementation is always crucial, but I was happy to see that that was the first recommendation, and that is something that we have addressed kind of to the bitter end in this state. Other things that we still have to do, things that are maybe not the first thing that you'd think of, but in our current technological landscape in 2023 are relevant. Things like addressing reverse demands. So making sure that law enforcement cannot request information about geofencing, right? Who was at this particular clinic at what time, or reverse keyword search demands, right? So who in Oakland, California, searched for abortion care XYZ at a particular time. We want to make sure that those laws and prohibitions are quite tight so that that information does not get in the wrong hands, whether they be California actors or outside of the state. So that is a policy that folks are currently working on. And back to Brian's point too about kind of California, we have a lot of great models and great laws that are protective of patients, providers, supporters. We also know that access is different than rights. And so my understanding is that 40% of California counties still don't have an abortion provider. So we need structural support, we need financial support, we need continued robust funding to make sure that everybody is actually able to access the services they need with whatever supportive services and practical support on the outside, right? Childcare, transportation, making sure that people can actually get from A to B in their lives and access abortion and other healthcare that they need. And then finally, I'll just say it's very important to harness the energies, which we have so much of in California, behind abortion, to other reproductive health and rights, and also to broader reproductive justice. And so I think that is kind of the point where many of our advocates and providers are, assessing the landscape, making sure that we are all set when it comes to abortion provision and coverage in the best possible way, but also making sure that we continue that conversation to make sure that we achieve true reproductive justice.
Thanks for that. Can I move then? Priya, may I move to you?
Sure. Dr. Pranay, would you want to go first or should I go?
No, it's okay.
Sorry about that. Yeah, sorry.
No. Okay, so in terms of challenges that we are facing honestly, we are very new post-MTP amendment. There are lots of challenges in terms of its implementation. I think the three key challenges that we are facing and that we've tried to address, but I think it's a long way to go. The first one would be to the continued judgment and bias by service providers. I think this is something that will take a long time to change. Dr. Aparna and I together, we set up something called the Respectful Abortion Care Initiative with the Federation of OBGYNs in India. It was the first of its kind initiative. It was based on WHO's Respectful Maternity Care Framework. We reached out to 44,000 OBGYNs. We recorded pre and post change in attitude in about 9,000 providers. I'm happy to share the paper if that's useful for people. It's published in the International Journal of OBGYN this year. While we did see a lot of commitment, but I think change is something that will take a long time. And I think Souvik, he also pointed out in the chat that there are areas, I mean, even 44,000 is too little for the population that is there in the country. So I think it will take time. While the new law does expand the service delivery of abortion, particularly medical abortion by registered medical practitioners, these are MBBS doctors that can provide services in primary healthcare, again, addressing their biases and, clarifying their misconceptions, etc., will take a long time. So I think judgment and changing the attitude of providers. The second one, I think it's the information that people themselves have. One of the things that happened post-amendment, I think for 1 year, we were so happy. Oh, we've, done our work. Amendment has happened. Everything is done. I think it was 2022, 2023. We didn't even want to think about abortion. We were thinking about family planning and gender equity rights and all of that. And I think it was all the way 1 year later when the Supreme Court passed a justice on a very small amendment in the law expanding services to unmarried women, where there was this whole publicity, news coverage, and people were talking about the amendment, that we realized, at least at WHO, that people, those are the ones that are going to access these services beneficially, particularly the young people, don't actually have that information. While we might rest on our laurels thinking that the law has changed, the people that actually need to use those services, for whom that law has changed, don't know. We ran a huge radio campaign through a very popular radio service called Radio Mirchi in India. We reached out to about 50 million people over a span of 2 weeks. That was also not enough. And I think that will never be enough in the context of India. It is something that will have to go on and on and on. Again, like the provider bias, not going to change easily. And the third thing, I think, which is particularly in line with the WHO guidelines, which is something that I think we are, as WHO, taking it up. WHO guidelines, I think, are very clear and a very good set of guidance for countries, whether it's India, Nepal, or any other country in the region. This is a broad framework that tells you what should be the case, what is the ideal. Now, countries often adopt bits and pieces according to what is available, what they like, what they don't like, or what might be suitable for the country. One such example is the use of medical abortion up to 12 to 13 weeks of gestation, as per the evidence, global evidence. But in India, it's only allowed to up to 9 weeks of gestation. In addition to that, while medical abortion commodities may be available in India, we did a huge landscape assessment and we found that there's a lot of quality of drugs issues. And this is not just in India. A lot of lower middle income countries, while we don't even, when we think of abortion, we start thinking about people, access, rights, etc. But something as basic as the quality of the drug, the mifemezo that is there, that is supposed to be given, the storage is an issue, quality is an issue, procurement is an issue, availability at the pharmacy is an issue. Those are issues that, even as public health practitioners, we don't even think about. And those are very serious issues that lead to, morbidity, mortality in abortion. And I think particularly in India, that is a challenge. That is something that we are taking up in a big way. So quality and quality of commodity availability, information among people, and judgment and bias among providers.
Thank you. Dr. Aparna, please.
Yeah, so I think Priya has covered most of the topics. I would just like to say that, with WHO guidelines, Government of India was stuck at 7 weeks, upper limit of medical abortion at 7 weeks for a very long time. And I think WHO abortion guidelines really helped us to extend it to 9 weeks. And I think that's one of the landmark things that has actually happened in the abortion care, this time, the act that came. The other thing that has really happened is that who can provide the abortion, right? So like in WHO says that you don't really have to be a medical practitioner, although India hasn't changed that. But there is one clause where the level of provision of guideline for medical abortion has come down in the current act, where you can provide medical abortion with an internship with a provider for providing at least 10 medical abortions. So I think that is something also which has come from WHO guidelines, where it says that, okay, you don't have to have too much of a skill set for providing medical abortion at least. So I think that is two of the significant changes where WHO guidelines have really helped. And I feel that any point in time, when we practice, when we talk about teaching, when we talk about, what steps to take, WHO guidelines do provide some credible roadmap on how to, take the things further. So having said that, our experience, apart from the huge RAC campaign that we launched with WHO India and, the FOXY, initially all of this started at an institute level. Like, we started with AIMS, where we talked about this Savor workshop. And I really feel that, charity begins at home. So we started with our own institute. We talked about, what are the reservations against provision of abortion, and just some of the things like, this Savor workshop that we talked about, where we talked about respectful abortion care. So we realized the deep-seated prejudices that the service providers have, even within institutes like ours, or even within the big institutes, which is actually hampering the access to care. And I really liked what Ruth said, that rights is different from access, and it's such a universal fact. So we first did this workshop in AIMS, where we had a lot of issues. They generated a lot of discussion around it, and with this initial experience, we did this at the level of the state, the Delhi state and the UP state. So this was our next experience, where we roped in private practitioners on a large scale. And and then we, in the dissemination of this guideline and also in the change of law. So we, at this point in time, definitely I would like to reinforce that two challenges that I really see is that the abortion care has a lot to do with personal beliefs. And despite knowing everything, the providers may still refuse to provide abortion, which has been really discussed as that. And yes, we have seen some of the feelings change, some of the ideas change around abortion following. So one is knowledge, which the RAC campaign really showed that, okay, there is a huge improvement in knowledge on what you can do around abortion care. But the other things are beliefs that are so deep-seated, that are so difficult to change. So I think that is something that would require a lot of reinforcement in those terms. And secondly, although a very liberal law is in place, the society as a whole has to wake up for the reproductive choices of women, because everything in a woman's life, if it's still controlled by the family, there is nothing much that she can really come out and ask for abortion. So India has taken giant steps towards defining women's choices. We are in the right direction, but the challenges are many, and it will take a while to realize this dream of reproductive freedom.
100%. And I want to say that both India and the state of California are meant to be kind of these beacons, these shining beacons, and you all raise the issues even within these places that are meant to be in the positive. May I, Ulrika, can I turn to you?
No, I don't know what you want me to say now.
Oh, I was opening to you also the question that I had raised with everybody else, right? So if there's anything that you would like to add about actions that are underway to secure abortion access, anything about the work around the guidelines, around the competencies, and anything that you're aware of that needs support or that is moving forward in good and positive ways. So it's a question both to you and Antonella at a more global level, now that we've talked about a state,
okay.
a country, and now we move kind of globally, if that's
sorry, I didn't follow.
I apologize.
Countries, we are continuing to support countries, whatever request they have when it comes to the competencies framework, when it comes to revise curricula or develop curricula, when it comes to strengthen health workforce. And for the future, we are hoping to be able to have key countries, especially in the African region, but also some countries in the Southeast Asian region, where we will give more focused support. Thank you.
Thank you. Antonella, will you allow me to let Priya speak before we go to you? Please go ahead.
Oh, thanks, Sophia. I just wanted to add that, we've worked very closely, at least in India, with Angelina and Ulrika to adopt the guidelines in interesting formats. I think I don't want to miss the opportunity to say that, whether it is the competency framework or it is the SAVER that Dr. Parna is talking about, which is the Safe Abortion Values, Evidence and Rights Toolkit that addresses the values. We have video games. These are all available freely online. I'm happy to share it with everybody. It's a game that people can play and go. I mean, we ask people to come to our workshops after playing the game. It's simply to test, which side of the, like what your own personal beliefs are related to gender, social, sexual reproductive health, men, women, etc. There also are some short videos about language on abortion, on conscientious bias, on what's right, what's not right, and this is all based on WHO's standardized evidence. I mean, at least in India, we found that we might not always have the time to explain everything to everybody, but WhatsApp is very easily available. We send out these videos on WhatsApp. We ask people to play games and get a report card and come to workshops. So I'm happy to share those resources. I invite everybody to go to www.savertoolkit.com. You can have these materials. I think Dr. Ulrika and Dr. Antonella, they worked very closely with us in simplifying these toolkits. And I think that is even moving forward. WHO has hundreds of guidelines. We have so many guidelines. One thing that is the key strength of our team, particularly, I think, working with Ulrika and Antonella, is giving the countries the freedom, the feasibility, the flexibility and the feasibility to adopt these guidelines to what works best for them. And I think with that, I'm just going to end there.
Thank you. No, just totally. Antonella, please.
So I think it's really important to also highlight that the guideline itself contains high-level recommendations, but not really information on how to operationalize those recommendations. So, we have the guideline in the 6 official UN languages and a few others, but we've recently been coming out with some additional operational tools. So that includes the update to the clinical handbook. We've got a law and policy evidence brief already, and we're working on a larger scale operational guidance related to the law and policy recommendations. But this is related to what Priya was talking about earlier, in that we need help in country to improve uptake. So, we will continue to work with our regional and country colleagues to disseminate these documents, but we're actually looking to all of you to help us in that effort as well. And dissemination doesn't just mean replacing old guidelines with new ones. It means making sure that the information is really accessible and understandable. And again, as Priya was mentioning, context specific. And we regularly collect feedback on all of these processes as well. So, we hope that you'll continue to share that with us. But one last thing is, it also means having difficult discussions, including ethical ones like the gestational limit recommendation that Brian had mentioned. We know that gestational limits cause barriers, things like delay, opportunity cost, system costs. I mean, the list goes on and on and on. But that's a regulatory recommendation. So we're not speaking about when abortions should or shouldn't be provided. We know that they're arbitrarily set and they're not evidence-based. But it doesn't mean that there aren't ethical implications for the recommendation. So this, like other issues in medicine where ethical issues arise, some more, some less, everything from sexually transmitted infection management, partner notification, palliative care, all sorts of things. It's important to consider how best to tackle these concerns, how to organize the care such that the patient and their needs are centered in that care. And so again, for these kinds of opportunities, I think there's a whole host of future collaborations that are possible.
Thank you for that. Priya, before I turn to you, I just want to offer to all the panelists, if you'd have like one last word that you'd like to say, I open that up. Just put up your hand, please, if there's something you want to add. Priya, please.
Oh, sorry. Okay. I just wanted to point out to everybody, you can go to the App Store, and WHO has a great tool. It's called the WHO CAT tool, the Comprehensive Abortion Care Tool. I have it readily available on my phone. It helps you with all resources, evaluation, latest news, everything that HRP puts out. So I just wanted to share that.
And we want to make sure that we make all these resources available to everyone. So one of the things that we can do is when we send out a copy of the recording, we'd be happy to list the tools that you all think should be included. Dr. Aparna, please.
Yeah, I think there's been a lot of discussion around conscientious objection. And I just want to clarify one more thing, that in India, under the MTP Act, a place has to be registered for abortion. The provider has to be registered for abortion. So if a person is going to a registered place and a person who's registered for abortion, it automatically means that because they have taken a conscious decision to get registered, they would not say no. And if you're not registered, it's a choice. You don't register your clinic, then you are not providing abortion. So I think that automatically falls under the Act. So essentially, this is a little bit, there is some clarity under the Act. Yes.
Thank you for that. Thank you, Rika.
Thank you. I just wanted you all to keep your eyes open because we are soon launching the medical abortion training program that will be for all providers. So keep your eyes open. I can share it also here with you, and then you can all access the WHO medical abortion training program.
Thank you for that, and thank you all. I mean, we are out of time, and I just need to say, I just want to thank all of you for your work. And the incredible stuff you all do, and really for the richness of the conversation. I truly learned a lot from this conversation. I'm really struck by the fact that there is just so much for us to do, no matter what our setting, and hopefully these kinds of conversations where we can talk to folks who are within our own settings, working in other settings, and working at the global level, that these are the kinds of conversations where hopefully we can move forward and we can have the sorts of difficult conversations we were saying are also necessary. And with that, I guess, let me say goodbye. I want to ask you to join us for this event that we have next week. But truly, thank you to this amazing panel and to all of you for being with us and for your interest and commitment to addressing safe abortion. Thank you, everybody. Bye.